Não me oponho. A questão é que os residentes caíram, penso eu. Portanto, então agora aqui não ouviram a parte da gravação.
Pronto, aí para o grupo que não ouviu, estávamos a dizer que a sessão será gravada, a não ser que alguém se oponha. Portanto, se alguém se opuser à gravação, que nos diga e nós paramos a gravação. Ok, então agora vou passar para inglês, que o Alex já deve estar a pensar o que é que nós estamos para aqui a dizer, ok? Alex, I'm sorry, it was a long speech in Portuguese.
No, it was interesting to listen to. I apologize. Obviously, my knowledge of Portuguese is very limited to non-existent.
Well,
I understood a word here and there, so
okay,
that's good.
But I will say more or less the same, so I will just explain the process. We will now enter into a dialogue, me, you, and Marcelo. All the other cameras will be shut down, so it's just the three of us on the screen. We will speak mostly about your experience in the NHS and your current experience, past experiences, whatever comes up, for up to 15 minutes. Up to, it can be less than that. And then we will shut our cameras off, the three of us, and the others will appear and will reflect about what they heard from us. And then we'll come back to us again for another 5-10 minutes. We will reflect on what we heard from them. I was just saying, this is an idea that came up from a psychiatrist in Norway, Tom Anderson, many years ago. He established what's called reflective teams. And it's based on hermeneutic circles. So we will interpret what we hear according to our own experiences. Okay, so I think we can start. I will ask everyone to close their cameras. Pedi a todos que fechassem as câmeras. Só eu, Alex e Marcelo é que mantemos. Okay. Okay. So now it's just the three of us. We have several people listening and seeing us, but
That's okay. I have my coffee ready.
Okay. So Alex, first of all, it's very nice to see you. I think I must say before we start that I know Alex for a number of years now. We work together in the same team in a drug and alcohol service in Essex and a national health service for about 6 years, I think, something like that. And
yes, I think since 2008 we know each other.
Yes, since 2008. That's correct. Yes, and we kept in touch every now and then, and I've just found out that Alex is he started recently, I think, a new position as managing mental health community service. Is that right, Alex?
Yeah, I'm a service manager for the community mental health in the southeast Essex. So it's quite a few different teams, isn't it? As you know, so the setup in England, there's a couple of what we call, we used to call them community mental health teams, and now it's sort of split into recovery and well-being and sort of first response teams. I also managed two early intervention teams, which is sort of the first episode.
First episode in what's called psychosis.
What is called psychosis.
Right.
But now, because we are sort of, there's a lot of transformation of mental health services going on. So we now have, I manage two primary care community mental health teams, where we have mental health nurses sort of based in GP surgeries, general practices.
Yeah, what we call family doctors here in Portugal. Yeah.
So that would be probably, it's sort of like in some countries called general practice, family doctors.
Yeah.
And I'm starting a couple of new services as well. So we're starting with Equipas community mental health team, which I hope will go live, well, end of January, but also what we say at risk mental state.
At risk mental state, yeah.
Service. So that is before the early intervention, and that is mainly sort of a service that is CBT. The CBT intervention and family therapy are sort of the primary interventions in that.
CBT, you mean cognitive behavioral therapy?
Sorry, cognitive behavioral therapy, yeah. So, you know, there's quite a varied array of teams sort of that I manage in the community.
Okay, so I noticed something interesting, which is the language seems to be changing a bit. So it's now called mental health well-being service. Is that what you said?
Yeah, I think that's it. Probably, and the language is changing. I would say in the past 10 years, you know, there is that, like any system, obviously the change is gradual. But you see, but the language is changing. So you know, you could say that obviously that medicine is still a very powerful perspective or medical model as such. Obviously, it is very much multidisciplinary, and you know, it is very much multidisciplinary in the sense that, you know, the role of psychology and what we call occupational therapy.
Yeah.
Not sure if there's what's in Portuguese, occupational therapy, but is very important. And what I think what's also changing is some of the practice and training. We're putting a lot of emphasis on, you know, the trauma-informed practice.
Yeah. That's very nice.
Mm-hmm. So you know, there is a lot of transformation going on, and there's been quite a bit of investment lately in, you know, mental health, and trying to sort of stop thinking of, you know, because, you know, systems can be quite regimented, isn't it? So we're trying to move on from, here in England we talk about primary care and secondary care. Yeah. So we're trying to moving on from that, thinking more and think more about in terms of the need and who can meet that need. So it's quite an interesting time.
Well, actually, it's interesting to hear that, because I remember when I was working there, I think medical model was much more influencing. So we were looking for a deficit, a diagnosis, and it was very much based on medication and a little bit of psychological work, but not much. But it sounds like it's becoming more less stigmatizing, I would say, more humanistic, perhaps.
It does, yeah, in a sense that I think part of it is that if you think about it, what we noticed, especially now, let's say with the pandemic, we did notice the impact of the pandemic and lockdowns and increase in demand. And part of it is obviously the, you know, the shared knowledge and the influence of that knowledge. And I think what is clear to everyone that in the way that, you know, the health service itself will not meet the need. A lot of this need is actually met with what we call third sector providers and voluntary organizations and charity organizations. So that is one thing. And the other is, as you know, is also the evidence. You know, the at-risk mental health service, for instance, is a good example, you know, that if you start, let's say, with some interventions like cognitive behavioral therapy and family therapy as a first intervention, not medication, you will find out that there will be quite a significant proportion of patients then who will not develop what medical model we would call, you know, psychosis, and then sort of have that treatment, which is often lifelong. So so as always, what we do is evidence-based, and it has to be. But I would say that it is multidisciplinary, and medical model is definitely one of the tenets still. But the language is changing, and I think it is truly multidisciplinary in that way that so that is quite as I said, I think it's quite a good time to be part of it.
A good time, but I imagine, as you were saying, evidence-based, there was a part of me that in a way it's necessary. I think it is important to measure what we do, but I also think that sometimes it becomes a bit mad and people take too much time filling forms and numbers, and I imagine that's still the case.
That is still the case, and that is one of the characteristics of the services in England. What I would say is what is really good about services here is how they're commissioned. We are very flexible, and in a sense that we're very flexible in working jointly with other services and sort of commissioning joint service. Like, for instance, one of the teams we're starting, it is quite complex in a sense, but you have National Health Service, but then you have also one of the third sector providers. And it's sort of
in Portugal, we are third sector providers, the foundation where
So it's like that, isn't it? We would have a joint project, and we would, for instance, that would be with the health service, and that's how it would be, and for instance, for the rough sleepers, with team that we're starting now, so yes, we have health-based psychologists and occupational therapists, but then we have peer support workers who are with homeless charity.
Right, peer support workers. And that's peer support workers, just to clarify for people that may not understand, they are
people with lived experience, we call it.
Lived experience. We in Portugal, we cannot find good words for that. So people who had past experience of mental health problems, right?
Yes.
Yes. Okay.
So I think in that sense, it's flexible. So, but you're right. It is sort of in terms of the formalities and recording, it is very time-consuming. There are two sides to it. I think in a National Health Service is very rich in data and information, and that data and information is very valuable, and you can learn a lot from it. And that's why so many other countries and even organizations are showing interest in having access to that data, because data today is, of course, very valuable. So, of course, it's all anonymized data, so to say. But so on one hand, that helps you making the decisions. On the other hand, it is very labor intensive, isn't it? So a larger proportion than maybe in some other countries of your work time you will spend in recording, measuring, monitoring, and so on. So, and that is the downside of it.
And you cannot measure everything, right? So
exactly.
The relationship and the quality of the relationship. But yeah, I was just thinking before we are almost getting up to our 15 minutes. I don't know if Marcelo has anything that came up so far with a question or something, just before we pass to the other group.
It's very interesting what you just told us, Alex. I was wondering if you could tell us a little bit more about, if you could explain us why CBT therapy and family therapy as first intervention. Because there are lots of models. Why are you choosing these two models?
Alex will say it's the evidence, right? But
yeah, I'm afraid so, because I think this obviously I think because the way it works, sort of, you have sort of the national, especially for the early intervention, you have sort of a set of national standards, and sort of this at-risk mental state service. It's not part of early intervention, but it sort of will work closely with. So in that sense, you know, it was nationally sort of suggested that these are the interventions that we would use, and the rationale for that was that there is evidence it is effective. I can't remember in what, where was the pilot, I can't remember at the moment, but I know that similar services were across, you know, some other European countries. I can't remember which one at the moment. I think it was Finland, but I don't hold me to it. So what they said is that there was evidence with CBT and family therapy, you know, you would have the reduction of people who would later on, you know, receive service from the psychiatry, secondary mental health. So I think that was it. So, you know, and I think there is a good point in that there's a lot of things you can't measure and they are important. I think one of the teams I established it was a new team I established about 4 years ago now, and we called it Intensive Outreach Team. And essentially, part of the reason for that team was, if you look at the studies on, let's say, what were the mental health outreach team, for instance, so these are the patients who really find it difficult to engage with the services the way they are structured, right? So, and if you look at what were the outcomes of those outreach services, in a sense, you know, there was no savings, public savings, because that is always some part of the consideration in commissioning. Because what happens, although people's needs have been met, inevitably you will discover new need, which again, so on one hand you will reduce, let's say, number of admissions and so on. On the other hand, you will discover new need, which again, you know, so there is no saving as such, but the most important outcome was the subjective perception of the quality of life that service users had, right? So not in terms of, well, you know, let's say there was less, I don't know, you know what I mean, the other things, but of everything that they measured, that subjective feeling that someone, you know, they had contact with someone, they were able to seek help if needed, the quality of life with sort of some practical things in their life, you know, has improved, and that subjective feeling of quality of life is important. You know, it is something that is difficult to measure. Obviously, you can measure how people report it, but you know, that was part of the rationale that we started that team, because the patient's journey, of course, outcomes are important, but patient experience is part of that. So you want patient experience to be a positive one. Yeah, sorry, Marcelo. So the basic reasoning why cognitive behavioral therapy in family is, yeah, sort of this was nationally said, well, this is the best evidence we have. So this is what we recommend you use. Okay. So it's very...
Thank you. This is why we must do studies in other therapies as well, so that they will become evidence-based. I'm afraid we are already out of our time, so I think it's now time for us to shut our cameras and to see what reflections come up from the rest of the people that are here. So for 5 up to 10 minutes, let's hear what they have to say, and then we come back for another 5 to 10 minutes. Okay.
Okay.
Okay, so we'll shut down our cameras now.
Well, it's up to us now. I think just only Sr. António. Okay. Well, let's talk about here, about the conversation.
I felt very calm in the speech of Alex, and not happened to me because my the question, the main question that came to my mind is how to get into the system, how to get there in Portugal. Because I feel very difficulties in Portugal. That's the question.
Okay. It's interesting that you say that Alex seems so calm. Now I noticed that because I feel that too. But I'm in my mind, I was uncomfortable with the English because I'm not fluent, and it's in my mind all the time because I understand what they say, but I'm afraid that you don't understand what I say, and that it's in my mind. But I will talk about three things that I hear a lot of things, but I choose to talk about three things. One of that is the changes of language. It makes me think about the importance of language because it's the preconception of how we look to things. And I think that maybe we are in the beginning of the process. The other thing is the flexibility. Because Alex talked about how different services can talk with each other. And I think that it's, how can we do that? Because it's so difficult in Portugal that we can talk with other services. And if they are public services, it's worse. So how can they talk with each other? I'm so curious. And I was thinking about the changes in the services and how it's for Alex to live that, the changes of the services. I don't know if someone else wants to talk. You are in mute.
No, I just want to explain that my presence here is mainly to learn about the technical issues and about mental health, because I am not a technician, I am not, I don't know, let's say, I don't know, I know what is for all the people, but for common people. So that's why I want to be in all seminars just to learn more and more. That's why maybe in the other seminars I'll ask something, but I am still learning, and that's why I'm not communicating now. Okay.
Okay, maybe we can go to the other group. I don't know if someone wants to talk about what did notice or feel about the conversation. So, João, I think we can change the group.
Okay, we'll put our cameras on again, and you disconnect again just for another 10 minutes, up to 10 minutes.
Yes, can I think it was really interesting to listen to the questions, and everyone's English is very good, so don't worry about that.
That's what I always say, but
I think where to start? Let me start with the language, because I think for me that is important. You know, the language and how we talk about different phenomena and you know, different presentations and different people plays a big role in, you know, reducing on one hand the stigma of mental health, but also it's sort of you know, when we try to build services that are, you know, multidisciplinary and that also, you know, are informed by people's lived experiences, language does make a difference, isn't it? Because on one hand, language can be inclusive of, let's say, lived experience, and then when professionals adopt sort of inclusive language, so, and I mean language, you know, that you know, it's not sort of difficult to decipher, do you know what I mean, sort of that we all understand what we are, you know, we're able to have a conversation regardless of, you know, service user, psychiatrist, social worker, psychologist. So that is one thing. Obviously, we all bring our own languages. In a sense, you know, if you're a psychologist, you will use different language than if you, you know, your service user who never studied psychology or didn't have much contact with. But that in a sense can be okay, you know. It's sort of you know, enriches the situation. I always imagine, you know, with the complex problems, there's not just one right solution. You know, it's only very simple problems only have one solution. Complex problems have multiple solutions, and they can, and many of them can be the right solution. So that's important to acknowledge. So language is something that, you know, we just need to be mindful of. But the other interesting questions that are sort of linked is the one thing that I do sort of appreciate in England is the flexibility of services, and then the question was how to get in the system. Well, and that is twofold. On one hand is, you know, from the institutions itself, change, I don't think that change is often initiated from institutions themselves. Institutions want to be stable, isn't it? But I think what helps is when institutions come to realization that actually, for instance, in order to meet the need, they need to work with others. And I think once institutions realize that, it is much easier. I mean, I'm just sort of, let's say, as an example, you know, if you, with service users, if you work with charities who, let's say, they have a befriender service for someone who is socially isolated, you know, so that means that, you know, that third sector provider charity can provide, let's say, this, the impact on mental health of that, you know, if someone is not socially isolated, is not well known. So we know it's most likely to have a positive impact when that social isolation is sort of, we can deal with that. Then on one hand, obviously we'll free resources of the, let's say, your service to provide more to other people, if you know what I mean. Sort of, so that is one, that internal realization that actually it's in everyone's interest that we work together. But the other, I'm afraid it is sort of, in a sense, also political in how things are commissioned. Because, you know, I really like the way sort of commissioning now is moving to, sometimes services are put in position that, and that is a decision that it was made on some level, that, you know, they will commission a service and they will want third sector or provider or independent provider and public health provider or a health provider to deliver this service together. And that sort of puts, you know, the framework that then services sort of have to work together. Then they come to these realizations. There's a lot of things we can do better together, and sort of, so, but that is a decision how the services are commissioned. But that comes with time, isn't it? And part of it is having conversations, you know, like you have conversations publicly, having conversations with, you know, people who influence decisions, doing the research, having evidence, I'm afraid is important, you know. Although we said we can't evidence everything, you know, but there is a lot of things that, you know, different pilot studies can show. So I think, yeah, sort of try to develop that flexibility, and sort of bring the importance to the people who make the decisions. And because what they often, you know, people who make these decisions, who are probably like, let's say, counselors or politicians or people who hold the purse, is that, you know, every money invested actually is money well invested and saved in the long term. You know, for instance, there's a good evidence, let's say, mental health intervention for people who are homeless or sleeping rough. You know, that every pound invested in that, the mental health of those service users will be repaid multiple times. In a sense, you know, that people will need less service later, or they will not end up in hospital for a long time, and so on. So that's why, yeah, I think it's mainly about the conversations. Of course, I don't know the system in Portugal to advise, but I think part of it is having those conversations with other professions, with other institutions, with the decision makers, work better together. And why is in patients' interest that, you know, these services can develop joint interventions. I hope that's sort of my view. I don't know, what do you think, Joao?
Well, I've been thinking many things actually. First, the word commissioning, I was concerned that some people could not understand that commissioning is to give money to some services, right? And I mean, we will open the discussion in a couple of minutes, and I think we can explore this more, but we are dealing with this problem right now in terms of making other services think that it is in their interest to work together, which is not always easy. Still in in Portugal, in certain areas, and I think services are still very isolated. And one thing is to say that they want to work together. Other thing is to really work together and to not feel they are protecting their own space. And because in practice, it's still very difficult, I think, in many parts of the country. Yes, that's what I was thinking. But I think, unless Marcel, unless you want to add something, I think it's about time for us to open to everyone and see what.
Yes.
Yeah.
Yes,
Is that okay?
I think it's a good idea. I think it's a good idea.
Okay. So let's open to everyone. I was concerned a little bit before I was concerned with the difficulties with the language. Katia was very brave she speaks very well, but sometimes she thinks she doesn't speak well. I could understand everything, but I was concerned that maybe other people are feeling either shy or with difficulties in explaining themselves, and some people may have not understood. So I also want to ask if anyone wants to ask something or in Portuguese, se alguém quiser dizer alguma coisa em português, because I also realized we had people from outside that I don't think, Sophia, did they not come? The people that were expected from outside? Okay.
No, nobody.
Okay, so it's more like an internal meeting. Okay. Portanto, estava just in português a perguntar em português se alguém sente que não percebeu quase nada e que gostava de fazer alguma pergunta em português.
Eu gostava que desse um ponto geral do que estiveram a falar, porque pronto, só tem...
Okay, some sort of a summary for António. Bem, é um pouco difícil estar... Pronto, vou tentar ser muito breve, não é? Pronto, o Alex esteve a falar dos vários serviços que ele tem implementado e que ele gera. Portanto, ele trabalha no Serviço Nacional de Saúde, em Inglaterra. Uma das coisas que surgiu foi a questão da linguagem, ou seja, ao longo dos últimos anos tem-se alterado a linguagem com que se aborda estas questões. Portanto, antigamente era muito baseado em diagnóstico, em linguagens estáticas, em encontrar o problema, o déficit, a falta e depois tentar remediar, tratar. A perspectiva agora é mais, por exemplo, o nome passou de serviço, unidade de saúde mental para unidade de bem-estar, por exemplo, ou centro de bem-estar. Não falam tanto portanto já não é tão centrado na pessoa do médico, mas é mais multidisciplinar. Um pouco aquilo que nós tentamos fazer na Casa de Algo, um bocadinho, não é, António? Mas que já noutros países já há muito tempo que se vai fazendo. Portanto, isto de alguma forma também era um pouco a intenção, trazer o Alex era um pouco essa, de mostrar que as coisas estão a evoluir. Já nos outros países já se vai evoluindo desta forma há muito tempo. Nós ainda estamos agora a começar a tentar mostrar que esta forma de trabalhar em conjunto com outros serviços, com uma linguagem mais inclusiva, com todas as profissões, não centrado no médico. O médico faz parte e é importante, mas não é a figura central.
João, isso posso acrescentar, que acho que é importante, acho que o Alex também disse, e não recorrendo de imediato aos psicofármacos. Não é?
Exatamente. Ou seja, o que eles têm serviços, por exemplo, chamados de early interventions. I still don't like that name. I will say that to you, Alex, in a minute. But um serviço chamado intervenções breves, intervenções, ou seja, pessoas que estão são jovens e estão a começar a demonstrar alguns problemas. E a primeira porta de entrada costumava ser medicar. E neste momento está-se a fazer nos serviços que o Alex gera, está-se a começar com coisas como terapia familiar, terapia cognitivo comportamental, ou aquelas que têm mais evidência, que têm mais estudos de investigação. E, portanto, muitas vezes evita-se que a pessoa depois, mais tarde, venha a tornar-se um utilizador crónico de hospitais, por exemplo, porque não vai desenvolver nenhum problema. Eu estou a dizer utilizador crónico de hospitais precisamente para não dizer doente mental. Sorry, Alex, I was just summarizing.
No, that's okay. I think it is difficult because obviously one is the language, but not just obviously just English and Portuguese. It's also the language that we use in different and terminology that we use in different countries, isn't it? Because we operate in different sort of systems. So not everything I say would be relevant for Portugal. But I would say it's good that different systems have different weaknesses and strengths. So there may be strengths in Portugal that I'm not aware of, that maybe you would know that actually, especially those who have experience in working, let's say, in other countries, that, maybe you can take, to your advantage, because, culture is important. I think good example is I was when I was working on the Rough Sleepers mental health team, I was reading quite a bit about homelessness in different countries. And I really found it interesting that, for instance, in Sarajevo, that's, as you probably know, capital of Bosnia, which obviously is quite a relatively poor for European circumstances, European context, and ravaged by civil war less than 30 years ago. They literally don't have any homelessness. Because in their culture locally, it's unacceptable for people to be homeless.
Yes.
And then you have much richer cities when you have big homelessness problems. So it's good to look into, like, in our own surroundings and see what are the positives and strengths in our own society, culture, systems that we can use. We can't really transplant directly one thing from one country to another. Obviously, there's some things that we have evidence, but there needs to be flexibility for adjusting to local circumstances.
Yeah, I was thinking, it's very curious that, because I was thinking in terms of, for example, in Finland, as you know, and we are working with this, trying to work with this system, they developed the open dialogue system. And it's curious because it's a country where at least people think that they are not very emotional, they are very organized, they are even cold personality, but actually they came up with the most warm and humanistic system that you could find. So it's curious that different cultures come up with different.
I think if I can just interject that, I think what is also then, because I know quite a bit of Scandinavian system. So, but what is interesting is that those societies are societies with a high level of trust. They have trust. They have high levels of trust, sort of interpersonal trust, trust in government, trust in public officials, teachers, high levels of trust. And when you have society with high level of trust, some things are actually easier to do. In societies, when you have low level of trust, you will have to record everything. If it's not evidence, it didn't happen. If you know what I mean, societies with high level of trust may be different. So but that's interesting. But we can still learn from these different experiences. But what we may find when we try to transplant it to that, there may be some local cultural, issues that obviously maybe we need to adapt what we're doing.
I think maybe, I don't know if other people want to add on this, but I think that may be one of the problems with working with services in Portugal, is a low lack of trust. And that also has historical, I think, reasons for this lack of trust, and for people to want to stick together within themselves and not working with other services. So I think that's probably part of it as well. I don't know.
I think the way I would approach that is sort of try to see, that other service, to see what is the benefit to them and their service users. That is one thing. But the other is, I think it's also the decision makers, isn't it? So who decide, let's say, how the service is delivered in some area. That's how I would approach it.
One thing that we will have on these talks is we have guests that are experts by experience, as you say, and we have families. And today we have here some of our residents at Casa de Alva. I'm curious to see if there's any comments or questions that they have. Alguma pergunta ou comentário que tenham aí da Casa de Alva. Marcelo, sim.
No, before some of the residents might want to speak, I just add something that came into my mind, which is the Projeto Manicômio. Alex, we Casa de Alva, Fundação Monte organized the international meeting in Lisbon, and the first day we visit. At the evening, we visit this place, which is called Project. How would we call
it? It would be Madhouse
Project.
Yes.
And so they receive the persons with mental issues, and most of them they were recovered during months. And so they are starting their lives. They want a new start. And this place receives all of those who have an artistic interest. They can develop there in that place an artistic interest. So we visit, and they were very kind. And I think there was trust. I felt trust in that moment as well between. They received this in a kind way, and they try to explain us the way they are working and how with great results. And they were curious about the way we work with mental health, and we were curious too, and we are interested in working with them and learning from them.
Can I say something on that, Marcel? Because this, what they called Madhouse, was just that's not a madhouse, but they came up with that name on purpose to
precisely
to demystify this problem. And they had the people that could work there, they had to have experience of mental health problems, but they were treated as artists, not as mental patients. And they were selling their artworks at the normal price, and they were participating in very in exhibitions in the most prestigious centers in Portugal and elsewhere. So I think that's one of the things that I liked, is because they are treated as people, not as mental patients. And they have the same status as any other artist. Actually, some of them are internationally renewed at the moment. They are really good artists.
And speaking about language, there was a kind of contradiction, because the person who presented us the Madhouse project to explain us the life of some of the users of the service, they had to use a diagnosis. So there is lots of work in progress, because we still need a lot the diagnosis to try to synthesize what is so difficult to synthesize, and that, I think that's another interesting issue.
Yeah, I think if I just add to the languages, what I would add is, that I understand what you're saying about the diagnosis, but I don't think that we necessarily need to just replace one language with the other. I think we need to enrich the language, you know, and with that we bring different perspective. And you know, someone, do you know what I mean? Someone may use the diagnosis because they can't describe something better than they use this, but you know, then there is other language we can use to describe that experience of that service user. So I don't think it's just about replacing the language. I think it's about having different perspectives, being truly multidisciplinary, and you know, bringing the language and including the language of the lived experience.
That's very interesting what you're saying, to enrich language. So it's like a great challenge to reach different languages.
Yeah, I think diagnosis, I think, can be part, and we have this. I know residents, the ones who are understanding the English, they many times they are wanting a diagnosis, which it's in their right to know. But the problem is that, at least from my perspective, a diagnosis is never static, and that's going back to what Alex is saying. It's one way of describing. There are many other ways, and actually it's changing. People are always changing. So if I describe myself only in one way as a psychotic person, I will be psychotic for the rest of my life. But that may be a moment in my life, and it can be described in many other ways. So yes, I think I agree with enriching, not limiting. But we can talk about diagnosis, but of course.
Yeah. So I'm not sure if you can hear me, or my connection is quite poor. Can you hear me?
There was just a difficulty at the moment, but so far it's been good.
Okay, good. Sorry about that. Yes, and I think part of it is, you know, as you say, you know, it's a really interesting example. I need to actually learn more about that, because, you know, this isn't it, and it's important that, you know, people we come across as service users, you know, maybe they, you know, let's say in the health service, they're patients, but they're also someone's father, someone's brother. They have a job. They may be a social worker. They may be a teacher or a mechanic, or, you know what I mean. Sort of, it's a sort of the problem is if we just sort of narrow down person to one, you know, with one description, it sort of take a lot of, you lose a lot of that person, isn't it? Then you miss it. So.
Actually, I was reading, rereading Tom Anderson and I mentioned him, and he has an example of sometimes we can say of someone like he is resistant, or he has a character of resistance. But another way of saying is he resists. And if we say he resists, we can ask, why does he resist? So we can understand the experience. But if we say he's resistant, we are limiting, isn't it?
Yes.
This sort of change, I think, is.
I think this change to why is really important. You know, when I started the intensive outreach team, one of the main things is because, you know, sometimes, you know, we can be quite descriptive. Let's say, you know, you have a person's history and you have sort of factual. This has happened and this has happened, and the person has done this, and what I try to change is move the conversations from what sort of descriptive to the question, you know, why. So why is, let's say, why am I behaving in this way today, or why is this person behaving in this way today? And just moving question to why, you know, it opens so many things actually that then you can actually address and resolve and help and find solutions, while the sort of with the description of that person, if that makes sense. But actually, you know, it's a behavior, and the question is, well, why? what has happened?
Mhm.
Why am I crying today? Something happened, you know, so.
Yes, yes, there's usually many explanations when we try to look at things.
Yes.
How is everyone doing? Como é que está toda a gente neste momento? Está sem som, Conceição.
I'm okay, I'm just learning.
Ok.
Maybe next time I'll ask some questions, but I'm learning.
Alguém quer fazer uma pergunta em português?
It's not a question, it's a comment or thinking. I'm thinking about trust and how can it link it with tolerar incerteza? I cannot say it in English.
Tolerate uncertainty.
And I think that maybe we, as professionals and services, maybe we are rigid, and we need to have the certainty about things, and we know if we do this, we'll have that response, and life is not like that. So I think maybe the effort is not for it.
Can I add something, Katya? Because I'm just remembering some past experiences with Alex. And for example, if I go back in time to the drug and alcohol service where we used to work, many times I felt that we needed to be certain because we would feel responsible if something would happen to that person. It would be our fault because we didn't make a diagnosis or we didn't give the right medication or so on. So to tolerate uncertainty and sometimes to do nothing is very difficult for professionals, I think, and they feel very insecure, and then sometimes they just act because they are afraid of the consequences. But sometimes acting is not the best thing, isn't it? So
I think that's a very good point, but I think the way I approach it is, you know, I think that institutions are inherently rigid, and I think that is not just negative, it can be positive as well. So I think like any system, you know, you need some central structure to be, for the system to be stable. If it's so totally uncertain, it cannot function, but yet sort of at the edges, you need the flexibility. Mm-hmm. So I think the way to deal with the institutions can tolerate uncertainty is if you sort of accept, okay, there is some uncertainty that brings some risk, there is a rationale for that uncertainty, and this is how I'm mitigating the risk. This is what I can do, if that makes sense. So, you know, so for instance, sometimes you need to make a decision that, let's say in the short term, may increase the risk, but in the long term, it will bring the positive result. Okay. And if you think about it, that happens in life often, isn't it? Let's say, I'm not sure what analogy to choose, but let's say when you have a surgery, you increase the risk in order to reduce the risk afterwards, isn't it? So, but then you need to manage that, isn't it? Uncertainty. So I think institutions need to, the way I manage is sort of that, to tolerate uncertainty. And you're right, it's difficult. Is that you know, I sort of acknowledge there is some uncertainty, acknowledge there is some risk, and then I identify how I can mitigate that risk and document it. And then I'm able to work with some uncertainty. And also it's about building some flexibility. For instance, let's say when we work with homeless people, isn't it? Sometimes, let's say it's difficult to say, well, when is the next time we will be able to meet them? Because there's you don't know where they sleep, you don't know will they stay in town, so you need to manage that uncertainty. And then sometimes for professionals that can be very difficult, isn't it? But then if you have the narrative of what you are doing, if you have a narrative that this is why there is this uncertainty, and this is in these circumstances what I can do to manage this, you're sort of, as a professional, doing the best as you can in those circumstances. Because I think the worst is, and the other is feeling compelled to do something, isn't it? Is the case as well. Because I think it's important that we do interventions that are actually helpful, not just respond because we feel we should start. Always there is then we do harm, and the first we need to do the interventions that are most likely have positive impact or worst case scenario neutral.
I think there's another level for me, another level to that, particularly in the work that is more psychotherapeutic, let's say, which is the tolerance of uncertainty. So sometimes we are compelled to act because it's just too difficult to be there and to listen to certain things, that if we open ourselves to these difficult experiences, it's much harder than just act and do something and to call the psychiatrist and medicate. And so I think that's also another level to protect ourselves from difficulties and to emotional difficulties. So and I think that happens in hospitals quite often because people, they are always confronted with so much pain that sometimes they shut themselves and try to put this rapid stick, not a rapid stick. No, this wasn't.
Yeah, plaster. Sticking plaster.
So we are approaching the end. So I don't know, people that have not asked anything, if they want to have this opportunity, or if you want to remain silent. This is the time to talk.
And you can talk in Portuguese. It's a very beautiful language to listen to. So
I know. Perhaps in the future, Alex will come to live in Spain or Portugal. So he's trying to.
I'm trying on some Spanish, but yeah, I'm not there yet.
Oh, really?
Just trying. I can say "Yo amo Alex" in Spanish.
Say what? How do you say?
Is it "Yo amo Alex"? No, "Te amo Alex"? No, that's different.
In Spanish, I think it seems like that.
Yeah.
In Portuguese is "Eu chamo Alex."
And in Spanish is
Yo me llamo.
Yo soy Alex.
That's Alex, yeah. I hope it was interesting. I mean, it's obviously different perspective. It's good to see, how things operate in sort of different environments. But as I said earlier, I think all environments have strengths and weaknesses, isn't it? And it's about trying to find our own advantages or resources, but also then learn from others as well.
I think that's a challenge that I think we must keep to ourselves, and to what are our strengths, and try, because language is social construction and language, they are very linked. So if we always use the language of we are not very good, we will become not very good, isn't it?
I agree, and sometimes it's easy to think that else things are always better elsewhere.
Yeah.
But they're different elsewhere, and yes, in some cases they may be better, but then we try to learn and pick up what's best, isn't it? But I do think that we can't always just transplant something from one environment to the other. I think it's important to take things in the local context as well.
Yeah, absolutely. We have two open dialogue projects at the moment, and we are certain that we cannot do the same thing as they do in Finland. It's just impossible. It's a different place. It's a different environment. So we have to understand how to adapt it to our context. Well, Alex, I think it was very, very nice to see you and to listen to your experiences. You are invited to attend the other seminars if you want. So we will be first Wednesday of each month at this time. Next time we have ex-resident from Casa de Algo. We'll speak about her experiences. The third time, I think we have a family member. So we will have a mixture of professionals, families, ex-service users, and so on. So yeah, for me, thank you very much.
Thank you, and thanks everyone for attending. And I wish you good luck in your future endeavors. And João, hopefully one day after pandemic we'll actually meet for coffee in person.
Yeah, I hope so. I hope so.
Okay, thank you.
Thank you, Alex.
Thank you, everyone.
Very much. Bye.
Thank you. Bye.
Bye.